when I spoke about the issue of knowing the community and social context, what I was referring to then was the issue of really trying to be culturally aware of the community that you as a provider or you as a healthcare system or you as a healthcare practice serve. Because being able to better understand the ways to culturally target and contextually adapt healthcare to the population that you serve is especially important when you're trying to serve disparate populations. And to do that, what do you need to do? You need to have meaningful partnerships between the health institution, the department, or the practice, and the community. And I spoke about the issue of trying to create standing community advisory boards. These are advisory boards that would meet on occasion, but will comprise key lay stakeholders from the community and key people in the practice or in the academic institution who could meet on a regular basis, better understand each other, better understand the needs of the community. For instance, we know that when it comes to research, for instance, minorities tend to not be enrolled in many of the clinical trials, pivotal clinical trials that are neurologic or are aimed at improving stroke outcomes. For African Americans, who are about 14% of the US population, only about 5% actually get enrolled in trials. For Hispanics, who are about 18% of the population, only about 1 to 2% of them get enrolled in these clinical trials, which is not optimal. And so having these kind of boards, having these kind of relationships could help to bolster the proportions of racial and ethnic minorities who are enrolled in clinical trials. It could help to make sure that the institutional practice is able to utilize resources of the community. Because again, if we're talking about the social determinants of health, it means that it's not just prescribing a pill, but you need to be able to understand how the patient who spends his or her time mostly in the community, how they're able to navigate that community and what are the resources that tend to support their health versus those that tend to detract from their health. And the other issue I mentioned was the issue of interventions. The great news is that we are beginning to see a few interventions that have been tested in clinical trials showing some promise in terms of improving outcomes for stroke in racial and ethnic minorities. Two of them really involved lifestyle modification approaches. So really trying to culturally adapt lifestyle modification approaches to the communities in order to try and make sure that they reduce their risk of stroke. In particular, in these cases, it was to reduce their blood pressure. One before stroke occurs, in the other situation was after stroke occurs. And these lifestyle modification approaches were imparted by nurses for the most part, or dietitians. And so it was really this utilization of allied health professionals to try and extend, so to speak, what the physician does within the hospital. The other thing that I should also mention is that I pointed out that this disparity has been, at least for stroke, when it comes to the racial disparity in the US, has been around for 60 years. And while we know that everybody has benefited, it hasn't narrowed or been eliminated. But there's one condition, and there's one group for whom, over the years, a really staggering disparity was actually reduced and then eliminated. And that was for end-stage renal disease in Native Americans. In 1980, the incidence of end-stage renal disease was 4 times higher in Native Americans than their non-Hispanic white counterparts. By 2013, it was exactly the same. It had been reduced completely, and it's one of the most prominent examples. What do? They partnered with the community. They made sure that the providers were aware of the impact of the community on the patients that they were serving. They made sure that every provider, whether it was a physician, whether it was an allied health provider, was steeped in the fundamentals of case management. They made sure that all providers were exposed to case management workshops, all kinds of training around evidence-based practices. But the big moral of the story there was that they didn't stop at the hospital. They made sure that they transcended the hospital in the community to make sure that that was part of the milieu in which the patient was being treated. And I think we can extrapolate that to stroke, hopefully, and maybe might see similar results. And then finally, the issue of growing the workforce. Diversity is important, not just for the sake of doing it. Why should we diversify the workforce? Well, because we know, number one, that because these disparities tend to affect populations who are not represented in the scientific or medical workforce. If we can bolster the numbers of those individuals in the workforce who frequently have a passion for wanting to go and serve in those vulnerable communities, we'll have more people who are interested in doing this type of work. In fact, when they've done surveys of people just going into medical school, you see a big difference in the proportions of minority, racial ethnic minority, would-be medical students who intend to serve vulnerable and underserved populations compared to their non-Hispanic white counterparts. When they leave medical school, you see the same thing. In fact, when you survey practices around at least the US, you find the same thing, that most of the practices that are in these vulnerable areas are pretty much populated by providers who are from those areas. So more the reason for us to do that. Other reason for us to diversify the workforce would be to, of course, encourage more people who are of race, minority race, ethnic background to want to go into the profession as well, to encourage more patients into our clinical trials. When you see a provider or a clinical trialist who looks like you may have a greater degree of trust, and that may allow you to feel that decades of mistrust from these communities towards the scientific world, towards the medical community, might somehow be overcome or mitigated if they have more people who look like them. So I think that's very important. The other aspect I haven't spoken as much about is the issue of global health. And so there's one thing to talk about disparities in high-income countries. So the disparities in high-income countries are in pockets. But what we know is that if you look from 1990 to about 2015, we see that drop of about 25% in stroke incidence and stroke mortality in high-income countries. But what you also see is a corresponding rise in the incidence of mortality from stroke in low to middle-income countries. And this is because as we treat infectious disease better, and as many of these low to middle income countries adopt more of a Western lifestyle, they're beginning to have these chronic diseases, which is now leading them to have a higher incidence of stroke and mortality from stroke. And so we have this potential epidemic in these low to middle income countries that is already occurring and is projected to get even worse with time. So that is something else that we all need to address. As part of my talk, I spoke about the work we are doing in Africa to identify the phenotypic characteristics of stroke there, identify the unique genetic polymorphisms associated with stroke there. We have a program called Talents, in which we're really trying to develop the workforce there, because I think, speaking for Africa, speaking on behalf of Africa, being originally from Africa, that the only way for us to be able to effectively bridge an epidemic of stroke is if we have people on the ground there who are capable of addressing the issue, finding solutions and sustaining them with time.